Good morning, everyone. Welcome to today's webinar. My name is October Boyles, and I am so glad that you are here with us today for this really important session on navigating telehealth compliance in 2025. What you didn't know would hurt you. And the reason I'm doing this webinar today is because I am in the unique position of getting to deal with clients all around the world, but also in the United States. We're seeing these kind of telehealth regulations and some changing landscape going on. And I'm hearing the difficulties people are having with telehealth, not necessarily people that are customers of ICANotes, but I do see other practices, large practices, small practices coming in that have had issues that they have faced with telehealth. And because of that, I felt like that this was an absolutely necessary thing to do. Again, I'm the compliance officer. I'm the chief clinical and compliance officer for ICANotes. I've been a clinical leader for over 25 years, and that has been in supporting mental health professionals, providers, practices just all across the country as they adapt to a lot of shifting regulations. And we've had more shifts in regulations over the past 5 years than we have the past 20 years. It is a very fast moving world today. So, what we're going to be talking about today is really clear, actionable, real world focused scenarios. And when I'm doing webinars, I like to give you examples. Unfortunately, there'll be examples that other people experience what they did and what you should not do. Okay. And so this is really an important webinar if you're running a solo practice, you're leading a clinic, I have folks in here I see that manage compliance programs, and that's great. So I'm going to give you a lot of tools and insights today to reduce your risk, hopefully improve your documentation, and just stay ahead of that audit curve. We're going to be talking about federal and state telehealth laws because they're still changing, and what you need to know about licensure, modality restrictions, billing, and things like that. So now, how many people, if I can just ask in here, are currently using? Let's do this. Let's first pull out. I just want to see, folks, if you feel comfortable sharing, like what is your discipline, or do you run a practice, and do you use telehealth exclusively in your practice, or do you just use it sometimes in your practice? So feel free to put your answers in the chat. Well, we have three different areas where you can talk during this, and I do encourage questions. Okay, I love questions. So you can use the QA. That's really hard for me to see, though. It's actually buried down deep in tabs. So you can use the public chat. But if you don't feel comfortable using the public chat or even the QA, which is public, you can private message me, and I'm happy to answer your questions privately. It won't say your name. We'll just answer your questions. All right. So it's great to see some folks already here. Gwen says, sometimes, Emily, I'm a solo practitioner, 100% telehealth. Fantastic. When a 50-50 split in person and telehealth, I like Elizabeth 70-25. We got all different splits here. Love it. Private practice, and sometimes since I'm a CCT therapist. All right. Excellent. Addiction counselor, hybrid position. Great. Clinical psychologist, nearly total telehealth, daily. APRN, fantastic. We do in person, telehealth, mental health medication management, fully telehealth, exclusively virtual. All right, excellent. 25% telehealth, 100%. Larry, 97%. Like it. 97%. That is very like those statistics. All right, great. Mental health, social worker, Cheryl. All right, excellent. Wilbur, Stephen, Lisa, Barbara, great. Okay, telehealth currently. Fantastic. It's great to have you guys in here today. All right, Darlene, I love that. Retired from paid practice, doing volunteer work for the American Red Cross, and use their system for documentation. Absolutely love it. Absolutely love it. Thank you so much for your volunteer work. So important. All right, great. All right, so I have a lot of variations in the way that people are using telehealth, and that's great. And what we're seeing is, and obviously from the way that you guys are answering too, telehealth is a permanent model, right? It is not a COVID workaround anymore, and there are a lot of risks now. That includes legal penalties, audits, and the most concerning thing is licensure loss, which we are seeing now. I have seen an uptick in that in the past 6 months. So this is why we wanted to do this webinar. And so we're just going to go over like learning some DEA and prescribing changes, reviewing the licensure and the RPM compliance. So a lot of you might not be familiar with RPM, so we can definitely talk about that. And identify billing and reimbursement false. But again, it's telehealth's no longer like the pandemic workaround, right? It is a permanent pillar of mental health care. But in 2025, the expectations are different, and regulators are no longer giving grace periods anymore. We're not seeing that. I saw an uptick in the third and fourth quarter of last year where payers were really tightening down on these documentation reviews. And so the question is not if you are no longer using telehealth, it's whether you're doing it legally and ethically, right? And in a way that protects your patients. And I loved all of you guys participating. And I will tell you, just out in the general population, 62% of behavioral health providers say that telehealth is their primary or preferred mode of service delivery. So we're definitely seeing these changes, definitely seeing these. Next, we're going to talk about, let me slip up slides here. I don't really go by the slides, so but I do have them up there, but I'm not really good at speaking. I don't read off my slides. I guess I should say that. But I will say that it's not just clinicians that like telehealth. It is consumers, your clients. They now expect virtual care. It's like mobile banking. It's an absolute expected. And we can't just say it's telehealth anymore. It's just healthcare. It's just healthcare. It's not a separate specialty anymore. And what I will tell you is 42% of mental health audits in 2023 involve concerns over telehealth documentation gaps, especially when you're looking at the main areas where consent, session type, identity verification. Now, I'm not going to give you a problem and not tell you how to fix it. Okay, so we're going to be going through that in these particular areas that I'm seeing that are popping up and being just real red flags for people. But I'll also say that 1 in 5 claims denials from payers just in 2024 cited missing telehealth specific modifiers or documentation elements. 1 in 5. So that's significant, and we really need to pay attention to that. Now, I am from the state of North Carolina. So, born and raised in North Carolina, I've had the opportunity to live other places, but North Carolina is mainly I did move to South Carolina for college, and I got to stay in Hawaii for a little while. So that was fantastic, but I'm back in North Carolina for the past 10 years, and North Carolina has some interesting laws. So, just out of curiosity, if you guys I'd like to, because I know the states that telehealth is the hardest to do with Medicaid. So, would you mind would you share your state in that? That'll give me some ideas of the audience that I'm talking to, because unfortunately, I know some of the states and which ones are the hardest with Medicaid, and there are states that are harder. So it's great. Lisa said I was born in NC2. Fantastic. You will be able to download the session and we'll send it to you. Absolutely. Oh, Emily, great. North Carolina too. Fantastic. Maine, Maryland, great. My notes is out of Maryland, so that's fantastic. All right, great. Virginia, neighboring state. Excellent. California. Larry, I always want to live in California. So the weather is much better in the wintertime. We still get pretty cold weather here. I am in the Charlotte region. San Diego. Oh, that sounds beautiful. Nevada, love it. Love it. Excellent. All right, great. Okay, so we have folks from all around. I'm just scrolling down the list now. This is fantastic. Okay. Excellent. All right, so we have a nice mix of people. So I'm going to be going over a lot of the states then, okay? But I want to tell you about a story about a therapist from North Carolina and what happened here. And this is just a cautionary case, okay? She got a $27,000 recoup notice from a major insurancer, and because they came through during a routine audit, and it was discovered during the audit that she failed to document whether the sessions were on the phone or on video. We're going to talk about that. She didn't note whether with a telehealth consent was obtained, and she didn't indicate how the client's identity was verified at each session. And all of that sounds like a pain, but I'm going to show you how to do it really easily. And the care she delivered was in absolute good faith, but she just lacked that defensible documentation that payers and regulators expect. And so her notes read like traditional in office sessions, and her EMR didn't flag any telehealth specific prompts. It wasn't fraud, it was just not compliance. So, this is why this slide really matters, because we want to talk about the appropriateness for telehealth, right? And that's one thing. Let me bounce over. Let me bounce over. We'll come back to I'll throw some slides together here. But with this is the compliance landscape, and we're going to talk a little bit about this. But if I go back to my last slide, it doesn't really list this in there, but we have to establish an appropriateness for telehealth. Was the client clinically appropriate for remote care? Were there any risk of suicidal ideation? Did you have safety concerns? Were there cognitive limitations going on that you needed to note? All your decisions need to be justified. And there a lot of people, and I've heard people say this over and over again, I just have one consent. It's fine. It has a blip about telehealth. Consents for telehealth must be documented and they have to be revisited. Like you need to go back and revisit it annually. And you can do verbal consents for telehealth, but it's best to do written. And you need to make sure that the client was informed of the risks, the limitations, their rights. Do they fully understand? And I'll talk to some stories about that later, but you also need to talk about, and people get dinged, was it video or phone? Because many payers and Medicaid programs only reimburse for video. I have the list of states, and your documentation absolutely has to reflect that. And then clients identification is always key. But if you're going to take anything away from this at all, I would just say that your standard note template you need to in your note put that your consent was obtained, if it was video or phone, that the client identity was verified and the client was assessed as clinically appropriate for telehealth. And for every new client or every annual update, you need to reconfirm and redocument that consent even if it's verbal. And what I keep talking about that, and you're like, October, that's great that you keep saying that, but what do I put in my note? What do I put in my note? And I'm not one of those people that likes to do webinars and then just tell you what to do and not tell you how to do it. So, what I would say in every single note, I would use very specific language like session conducted via HIPAA compliant video, which we can get into a little bit later, client's identity verified visually, client continues to demonstrate clinical appropriateness for remote care. Telehealth consent remains on file. That is your banger statement. When they're doing an audit review and they see that in the note, they know they can't get you. All right. Now you're like, okay, you probably said that really fast. So what I'm going to do is I'm going to drop this in the chat so you have this and you can just copy and pull it directly from the chat. Yeah. If people are like, can you repeat that? Absolutely. I'm going to stick it right in the chat, but I will repeat it as well. But here we go. I'm going to send that out in the chat. Could you put that in the chat? Yeah, I dropped it right in the chat. Absolutely. Absolutely. That statement right there will shut an auditor down completely. All right. It will shut an auditor down. I'm looking right now. I have an auditor in here. And you're probably going to be like, October. Yes, I think people should have cheat sheets. Okay. I absolutely do. Absolutely do. So, because I know what the auditors are looking for. And once they see that, that's it. You have covered all of it right there. Leslie says, I'm not seeing it in the chat. Let's see. It's not in the QA. I can drop it in the QA. Let me put it in the QA. QA is a little bit difficult for me to get to. Here we go. So I dropped it in the QA if you're looking at the QA over there. All right. Excellent. Excellent. Okay. Fantastic. Okay. So let's go ahead and we'll just keep it moving. Did you say how often to obtain telehealth consent? We update every 6 months. I like that. It's better to be safe than sorry. 6 months is good. You would not want to go more than a year. You would absolutely not want to go more than a year. So, Karen, if you're doing it every 6 months, you are in a good spot. All right. Absolutely. Okay. So, slide on here. Now, I want to talk about some of the providing care across state lines. Okay. This is how many of you, because look, I have a friend and she has 11 licenses, 11 state licenses, and she is a nurse practitioner and she practices in 11 different states. How many of you guys go across state lines? How many of you? I just got a question. Did any template of a telehealth written consent? We do have them in ICANotes. I do have what I know should be in telehealth consent, but I don't have one right offhand. I have a telehealth checklist to share with you in handouts, but I don't actually have a consent. I'm sorry. Maybe that's something that I can get out in a blog post. All right, good. We're getting great response in the chats. Let me go through some of these to see. All right. So we have a lot of people that are doing a lot. We've got 40 states. Awesome. Yep. That's that was the psych pack was actually what I was going to talk about. So good. 3 states. Very good. All right. All right. Some of you guys doing one, some of you are crossing state lines. And listen, I think it's a great thing to cross state lines, especially if you're trying to expand your business, you're trying to expand your practice, get people underneath you. I think it's a great thing. And listen, I'm licensed in North Carolina and practice for both state, which insurance. Some insurance companies don't like it. You're right, they do. But there's not a whole lot they can do about it either. So good. Alabama, North Carolina, fantastic. All right, great. Love to see you guys doing this. This is great. Okay, so let's talk about when we're talking about kind of the compliance landscape. Now I know what you guys are doing here. Federal law equals the minimum, and state law is a lot stricter. And I'm going to give you some examples of that. There's the Ryan Act and the DEA's kind of Ryan Act. There's payers like Medicare, they add billing rules on top of stuff. There are industry standards out there that influence expectations. But I want to talk a little bit about HIPAA, okay? You all know HIPAA, it governs PHI. PHI is protected health information. It requires secure video platforms, privacy notices, and safeguards during remote care. All right. And then the F42 CRF Part 2, a lot of people have heard that, but they don't understand that adds actually stricter protections for substance use and treatment records. And there can be no casual mention of addiction history or treatment without proper consents or protocols, even across clinical teams. Okay. So substance use is always held at a much higher standard. All right. Now, let me give you an example of a pitfall. There was a small practice in Colorado, and they received an OCR complaint because they use FaceTime, which was a non-HIPAA compliant platform. This was the post PHE for telehealth intake. All right. And it involved in that intake it had opioid treatments in there. And they didn't have proper consent under the Part 2. So there was an investigation into that. There was a mandatory corrective action. And then I think it's reputational harm. When these big agencies know your name, I don't like that. Okay. So that is a good example of, and somebody said in the private, what is PHE? So she used FaceTime, and FaceTime is not HIPAA compliant post PHE, and PHE is a public health emergency. And that was the kind of the formal federal declaration. It was the Department of Health and Human Services. They issued that in response to COVID. It started, I think it was January 31st, 2020. Remember when they said we didn't have COVID? There's no COVID. Yeah. They instituted that January 31st, 2020, and they renewed it every 90 days. And it officially ended in May of 2023. But see, people just didn't pay attention to the fact that it ended, right? And during that public health emergency, all of those telehealth regulations were relaxed, right? And you could prescribe controls without in-person examinations, and you could use non-HIPAA platforms, compliant platforms like a FaceTime, right? And you could get reimbursed for audio only sessions. But those times have changed. They absolutely have changed. And we're not hopefully we're not going to see those times anymore. So now there are state specific laws, like you've got to be licensed in the state where the patient is physically located at the time of service, even if you're just across the border. Telehealth doesn't override state boundaries. So you always need to verify where the patient is. That could just be like, hey, I just want to check, are you in North Carolina today? Or are you at your house? Or just find out where they are. It's good for you to find out where they are. And let me tell you why, too. Because there might come a time, I hope it never comes for you, but there might come a time that your patient states to you on a telehealth session that they are ready to take their life or a life of another person. That has happened to clinicians. And this one particular clinician it happened to, she didn't actually know. She didn't ask. She didn't know where the patient was. She didn't know where to call, like who to call. She had an emergency contact, right? But unfortunately, they were threatening the life of the emergency contact. So know where your patient is. know where your patient is, and just ask them really quick. Just make it a nice little part of your conversation. You guys are master communicators. You wouldn't be in here if you weren't. You communicate with people all day. You make them feel good. So just throw something in there about, "Hey, where are you at?" Just checking. So that is one thing that I would absolutely do. It's just confirming because you gotta put it in your note, right, that they're located. I would even go so far as sometimes putting they're located in, let's say, South Carolina at the time of session or Virginia at the time of session. Exactly. And then I will tell you the 20 okay, I've got some questions here, so I wanna stop for a second. How do I know if my telehealth platform is HIPAA compliant? First thing and foremost, your telehealth vendor has to provide you a signed BAA, okay? And that's required under HIPAA. And very good. Cheryl already came in with the win. All right, go Cheryl. Absolutely. So they've got to have that BA. Another thing they need to have is encryption standards. So that platform should have end to end encryption, both in transit during the call and at rest when it's stored. So you need to ask your vendor if they follow it's called NIST recommended standards for encryption. Okay. NIST recommended standards. And it also each platform, just like ICANotes has all of that, but it also has access control and audit logs. So we can tell when you logged in, we have role-based access and detailed audit trails for anybody that accessed PHI. All right. So if they don't have a BAA, they are not compliant. I will tell you, FaceTime, Skype, Facebook Messenger, none of them HIPAA compliant. None of them. And there are free healthcare or free platforms out there, but a lot of times they don't have a healthcare plan, and those are pretty risky. So I'd ask for a B and for a security and privacy statement or a third-party risk assessment report. Okay. Very all right. Let's see. And Larry Goodman said, "No, Sandra, dangerous. I've been told I can be anywhere in the world. And my client can be anywhere in the world as long as they're a resident of the state I practice in, and my license allows me to see them." There's a little bit of truth to where you can be, Sandra, but and we're gonna talk about that, and there's a fine little line, and we're gonna walk it, okay? There's a fine little line, but your client has to be in their state, okay? Absolutely. All right. Let's see. And I wanna talk about I'm gonna get through this is the toughest slide I've got, but I wanna talk a little bit more about the always what we talked about, verify where the client is during session. Audio sessions, the CMS Medicare billing rules that you see listed there, audio sessions are still reimbursed, but only under very specific CPT codes and with documentation that the video was unavailable or declined. There are some people that do not want to get on video, and as long as they decline it, that's absolutely fine. And as long as you speak to that's okay. But place of service code matters. Like you could do a place of service code 10, patient and home, or POS, place of service code 2, anywhere else. Like errors here can really trigger audits and denials. So you want to be really careful. You can use modifiers 95 for telehealth services, and you can include place of service code that matches where the patient is at. And when I asked the biller, we have a RCM team here at ICANotes, and I said, "Hey," her name's Fatima. I said, "Fatima, I really want to talk to and get into billing because I know I'll have people ask me questions like with audio sessions and place of service codes." And she said, "Listen, you got to check under their payer rules for the telehealth in general because." She said, "I know UHS no longer requires a GT or a 95, but they will often deny claims if they have them for invalid modifiers. They never announced it, but through trial and error, I've noticed it." So I thought we could have a whole nother billing session just on telehealth. Okay. So absolutely. But I think it's important that you know those things. One thing that I want to talk about is the Ryan Act. And what that is, this is post public health emergency as of 2025, because I saw we have a lot of prescribers in here. You must conduct at least one person visit before you prescribe controlled substances via telehealth, unless you're under specific exemptions and or exceptions. And that exception would be that you participate in a DEA registered telemedicine registry. And if you're like, "I don't know what that is. What is it?" You're not part of it. Okay. So yeah, absolutely. And I'll tell you, this happened not too long ago. There was a psychiatric nurse practitioner in Georgia, and she lost her DEA license for e-prescribing stimulants to a college student that she had only met via telehealth. There was no in-person demand at all, and that violated the Ryan Act. And she believed that the pandemic rules still applied. So that's why it's so important that we're having these conversations right now. Somebody just said, "What is the Ryan Act?" The Ryan Act, it's been around for a very long time. Okay. It's been around since I think it was like 2008 or something like that. But there was a young college student. I think he was a very bright young man who he just tragically died because of an overdose of Vicodin. He bought it online. He never saw a doctor. It got sent to him by one of those sham pharmacies. And so it was like one of those rogue internet pharmacies, and they dispense it to him, and he overdosed on it. And that law requires that everybody has at least one in-person medical evaluation. And here is the thing, but that was suspended during COVID. It was suspended during COVID, and some people just haven't caught on that you can't do that anymore. Let's switch off right now because I want to be cognizant of time, and I want to make sure I answer your question. People are saying, yes, doxy me free. Yep, you make sure it's got the stuff in it. Absolute Psychology Today, free and better than Doxy. Okay, some people are recommending some things in here. Somebody said, "Does ICANotes?" Yes, we do. We absolutely have telehealth within, and you can have it on your screen type. So yes, it's a great program. I don't know how much it is a month. Is it $10 a month or something? Absolutely. I want to talk about some regulatory shifts. Excuse me. Many states are requiring insurance to reimburse telehealth at the same rate as in person, and that's great. Those are some parity laws, but only if the documentation elements are equivalent. So make sure your telehealth notes look just as comprehensive as your in-office notes or your reimbursement, because your audit that could suffer. Somebody brought up the PACT law, and I'm super happy that they did that, because there are these interstate licensure compacts. One applies to like psychologists in over 35 plus states that allow practicing across lines. There is the Interstate Medical Licensure Compact that applies to MDs and DOs, and that can get streamlined in licensure up to 37 plus states. And then there's a counseling compact and APRN compact. It's growing, but it's not fully nationwide yet. So know which compact applies to your license and enroll early to future proof your practice. Okay. All right. Let's see. The final flexibility at the end of third. Yeah, I wouldn't. No, I just told you the story about the NP in Georgia. That was very recently. So I would in person. Just do a one in person. So one in person. That was This is happening. You don't want to be made an exception of, because unfortunately with that young lady, she lost her DEA license. If you're a nurse practitioner and you lose your DEA license, your ability to practice is essentially gone, correct? So we do not want to play with that. Regina says, if a client goes on vacation in another state, can we still see that client? I have an excellent example of that. So let's just move forward then. I got an excellent example of that one, and I want to talk to you about that because this has happened not once, but twice. So this is providing, this is my very next slide. So glad you brought it up. Patients in a different state, even temporarily, you must be licensed or authorized under a compact for that state at the time of session. And let me tell you, I got some stats for this, and it's not good. In 2023, I don't have 2024 stats. I like to have new stats, but this is 2023. 22% of all telehealth related disciplinary action by state boards involved unauthorized cross care of state lines. Okay. So and this is what happened. Let me tell you the story. There's a psychologist in Illinois. I will never use a person's name, but there's a psychologist in Illinois that was fined and reprimanded after providing regular therapy sessions to a college student who moved back to Ohio for the summer break. And she never confirmed the client's location change. And the Ohio board pursued action for unlicensed practice. So always ask them, document where they are, their physical location every session. And listen, I put that big thing in there that you can put in your charts. You could simply say client confirmed they were physically present in North Carolina at time of session. Okay. That's it. At ICANotes, we have these little custom buttons that you can hit every single time for your note, and it just pops right in there. Okay. That's what you need to do. That needs to become a part of your documentation because later on, when they pull your documentation, you physically, let's be honest. Okay, let's be honest. And let me tell you a little bit about my background. I'll just spend 60 seconds. Before I came to ICANotes, I worked in leadership and behavioral health, but I did a stint for some time with one of the largest law firms here in the Southeast, and we protected clinicians and hospitals and big practices. You could not be a patient and try to come sue someone to us. Like we protected it was the big healthcare systems. All right. And I worked as an expert for them on many cases. And so I have seen the documentation, and what I will tell you, because unfortunately I had to meet with the clinicians and get their story and look at the documentation and see if we had a shot of protecting this clinician or we should just settle. And what I can tell you is 9 out of 10 times, the clinician doesn't even remember the patient suing them. They don't even remember. So there's no way that you're gonna when the auditor comes in and asks, "Where were they when you saw it?" There's no way you're gonna remember that. So you do too much. You work too hard. Like you see a lot of people, you're not gonna be able to remember it all. You were absolutely human. So just document it, and then you don't have to ever worry about it. All right, I'll get off my soapbox. Okay. I will get off my soapbox. So that I do just want to talk about again, you do need to talk about like consents, then their location, and then the modality of that. Because notes that look like in-person sessions that aren't, they don't say telehealth, they are audit red flags. 42% of mental health providers fail to document the modality of the telehealth sessions. All right. And that came out of CMS's Office of the Inspector General. So I know that there is a small group practice that they got $18,000 denied in claims after an insurancer audit just showed up and looked at their notes, and their notes didn't specify whether the sessions were video or audio or whether the client's identity was verified or again, the care was legitimate, but it just wasn't defensible on paper. I would use a checklist, which we are provided in handouts on every session to confirm, like, do I have a consent? What is their location? What modality, video or phone? What was did I get their identification? And was it clinically appropriate? All right. And I would avoid using incorrect place of service codes or modifiers, right? Because those can lead to denials and overpayments. 35% of Medicare telehealth claims audited in 2023 had incorrect modifiers of place of service codes. So there was a counselor, she submitted sessions using the modifier 95 with the place of service code 11, which is in office, instead of the place of service code 10, client at home, and Medicare flagged it as intent to misrepresent, and it triggered an expanded audit. Listen, she had no malicious intent, but intent isn't required for penalties, right? So remember, place of service code 10, client is at home. Place of service code 02, client is elsewhere. That could be school or the car. That's those, know your place of service codes. Somebody was talking about consent. Telehealth specific consent is not the same as a general consent to treat. I've said that 100 times. I'll continue to say it. It's got to include the technology risks, the limitations, the privacy concerns, and the patient rights. And only 57%, if you're like, I don't have that, 57% of clinicians surveyed in 2024 said that they obtained specific consent for telehealth before care. That's only 57%. So that means that there's a lot of people not doing it, and that's okay. But I will tell you again, I like to pull in the real world stories. There was a client in Texas, and they filed a complaint because she said she was never told that the sessions were being recorded by the platform's default setting, and the therapist had never explained the platform privacy or the limits, and the licensing board in Texas issued a warning for inadequate consent. Now I know that when you get in there that y'all talk about I'm sorry, let me just say this. Let me just say this, and I'm going to try to maintain professional. But in all platforms, if you're being recorded, there's a little light that's usually blinking, right? Or it says recording in process. You see it on the screen, but the lady said she didn't see it, and this poor lady got a warning. So You've got to be really careful about that. But I think the takeaways from here is you have the telehealth specific consent form and you talk about risk of a disconnection or breach, you talk about security limitations, and you talk about emergency backup plan. Okay. So I think that is something that you really need to do. And the reason, again, that we're going over this is because the OCR reported a 33% rise in HIPAA complaints involving telehealth platforms. There was a provider, even, I have a lot of stories. I'm not going to tell all of them, but there was a provider who was reported by a patient after they used WhatsApp for therapy. Now, I have no explanation for that. But WhatsApp doesn't have a business office associate agreement, and that provider faced some HIPAA scrutiny, and they had to complete a mandatory corrective training. So only use platforms that have BAAs, right? So if it doesn't have a BAA, it's not HIPAA safe. All right. I want to take some questions here, and then I'm going to get back. We're going to talk about, I promised you guys I was going to get into the states, which I absolutely am. So let me say, let's see. I got a lot of questions here. So give me a little minute to go through there. Somebody says in Maryland, okay, the DHA and HHS has extended the pandemic era telemedicine flexibility to the end of 2025. Okay. But in Maryland, follow-up prescriptions, you can issue a follow-up prescription during, but you have to be licensed in Maryland. And Maryland mandates electronic prescribing for controlled substances. And you're supposed to do your PDMP checks in Maryland too. That's a whole nother webinar on what states have to do PDMP checks and which don't. But in Maryland, you're supposed to do the PDMP. That's the Prescription Drug Monitoring Program. It's across the United States before issuing prescriptions for controlled substances. So, like in North Carolina, I live in Charlotte, which is very close to South Carolina, and we used to have patients and some of the clinics that I would go to that would come into North Carolina, get maybe like some amphetamines, and then go to South Carolina and see a provider in South Carolina. PDMP makes sure that doesn't happen because it checks it across all the states. All the states, okay? All the states. So let's see. Can I have a PA giving a telehealth session from a different state? This question is coming up. I'm going to save this question for last, but absolutely. This is one we need to tiptoe around, but I think it is a good question. If a client on a temp vision, can we see them but still send a script to the home state? And can the patient and patient can move to a local temp pharmacy or pick up the script when he returns? If your patient, I'm trying to make sure I understand that if your patient is temporarily out of state and you send a prescription to their regular pharmacy in their home state, and then they can pick up a medication upon returning home. Is that what you're asking? This is generally straightforward if there's no controls involved. But now I know for controlled substances, like especially Schedule 2, like a stimulant, we were talking about stimulants a lot. So there's a one-time transfer, like a DEA will allow a one-time transfer of an electronic prescription for controlled substances between CVS and Walgreens, and it's permitted under the state law. Okay, I do know that, but some states have like additional restrictions on. So if I was you, I would check the originating and the receiving state's pharmacy laws. All right. But if it's CVS and Walgreens, they usually have that in place. Let's see, a couple of more work questions here. I'll get back to the slides. I'm just reading these. You guys got great questions. And I said, can you put the statement about the location in the chat? Absolutely will. I'll type that out. Let's see. Karen said, are you finding any issues with insurance companies demanding use of a telehealth platform that they offer in order to reimburse Blue Cross Blue Shield? Was saying that. Yeah, Karen, to answer your question. Karen saying, are there insurance companies demanding you use their telehealth platform that they offer in order to reimburse you, like Blue Cross Blue Shield? Yeah, that's a growing concern. And you're absolutely right to bring it up. Like Blue Cross, they've tried to get clinicians they've tried to require them to use like their proprietary telehealth platforms like Amwell or Teladoc, or I know what you're talking about exactly. So here's the problem, okay? This really undermines your ability to be able to choose a HIPAA compliant platform that fits with your workflow. and your documentation needs and your patient's needs, because not all telehealth platforms are created equally. Okay, I'm just going to say that. Yes, I think it raises a lot of ethical and privacy concerns because, listen, you have less control also over how your patient data is being stored and transmitted and accessed, especially if it's a third party user platform. And if that platform, like Blue Cross Blue Shields, if that has technical barriers, like it's not mobile friendly, you got to download a bunch of apps, and it doesn't support audio only, then that can really impact, like, disproportionately impact elderly or disabled patients. And I want to talk about that a little bit later. But yeah, to be clear, that is one of the reasons they want you to use their telehealth platform, right? Because they want you to not do the audio part. Excellent question, and brought up something that is really due. But there are state laws that will prohibit what we call network steering, and you can check with the Department of Insurance of your state because you can push back with some policy language on that. Absolutely. Like, where I don't see this in my contract. Can you where's the regulation that supports that? And if they give you a real hard time, you can contact that state insurance commissioner, okay? Yeah. Excellent. Let's see. I'm going to answer one. Can you put in the state? I will put in this statement. Absolutely. So, you can push back on that. You can ask for written policy clarification on that. All right. Because it's your license, it's your workflow, and it's whatever platform you want to use. And that shouldn't be dictated by a private payer if you're in good standing, right? Absolutely not. Okay. You got October feisty during the webinar, but yeah, I've heard of that and I don't like it. Okay, let's go over a couple other things. And I am going to get to your question. Don't worry. I will get to all questions here. I do want to talk about, I want to go back to Medicare telehealth claims. 17% of them were denied in 2023 due to noncompliance with eligibility or documentation requirements. The, and I'll give you an example. A therapist billed Medicare. They had phone only sessions with older adults in rural areas, but failed to note why video wasn't available, and all that therapist claims were rejected. So if you're using audio only, you're going to document that the video was unavailable or declined and that the session was medically necessary. That's your zinger. Video was unavailable or declined and session was medically necessary, and you need to use correct CPT codes like 99442. Okay. And so now there are states that have known restrictions or no mandates to cover telehealth only. And some of those is like Idaho has limited Medicaid coverage, right? And the commercial plans are not required to cover audio only. Florida generally discourages audio only. Texas allows audio only under Medicaid, but commercial insurers might not cover it. Tennessee requires justification for audio only and often limits reimbursement. Often. North Carolina allows it, but the reimbursement is inconsistent. Mississippi, it permits audio only, but wants you to document why. And Arkansas rolled back recently audio only for a lot of services except crisis ones. And it's still like letting some mental health things go on. And then South Carolina has Medicaid on allows audio only in limited cases, but the commercial coverage is not really clear. But there are states that explicitly allow or reimburse for it, and that's like California, New York, Oregon, Washington, Colorado, Massachusetts, New Mexico, Arizona, Michigan, Pennsylvania. But as long as you document why you didn't use it, like they didn't have access to that technology. They have a flip phone. What do you want me to do? Or the patient just they don't want me to see them on audio. They feel perhaps they're unkept, they don't feel good about themselves right now, and they don't want to be on audio. And as long as you have the consent and you document why, you should be okay with that. All right. I'm going to move off the slide, but I'm going to say, let's see, I'm answering a question here. As a newly graduated psychiatric mental health nurse practitioner, good for you. Congratulations. It's understandable to observe the proliferation of telehealth practices prescribing controlled substance and questions the regulatory landscape. While some practices may reference obtaining documentations, the PCP, I'm going to speed through this, is a basis for patrolling. Is it crucial? It's crucial to understand. Yes, it is. Yes. I'm glad you put that in there, and congratulations to you. Absolutely. All right. Okay, I am going to slide off this one because I am behind in my slides. I'm on 5. I'm on slide 5 of 15. So we're going to 6 and we are just going to move right along. Okay. All right, we're going to, let me slide past this one. We're just going to keep it moving here. All right. Actually, let's go back just one because there is one key point here that I'm not going to go into our RTM codes. I don't, how many of you know what RTM is and are you currently doing it? How many of you know what RTM is and are you currently doing it? Just type yes in the chat if you are. You will get copies of the slide. Absolutely. Absolutely. Absolutely, you will. No, no idea. Okay. It's a way of remote monitoring. You can get paid for it. You can get paid for it as a mental health clinician if you see their heart rate, it goes up for anxiety or their blood pressure is going up for anxiety, but it's a really good opportunity for mental health clinicians to pair with primary care providers because they are reimbursing for like remote care monitoring. Okay, they call it remote therapeutic monitoring. And it is really, it's an additional way to make revenue by monitoring your patients. I think it's great. All right, so I will say, and I apologize, there's like an alarm going off behind me. I'm sorry. There are red flags that can trigger some telehealth audits. I do want to talk about those really quickly. If you, as a therapist, you've consistently billed 60-minute sessions, if the note doesn't support the full time, and Medicare and private payers, they flag high frequency billing of 90837, especially using telehealth with potential upcodes. So just be aware of that, okay? Just be aware of that. The rest of this, I'm not going to go billing out of state without authorization if you're not licensed again. And let me give you an example because somebody asked this as a chat. I think this is a perfect example. There was a psychologist who billed Blue Cross for sessions with a snowbird client who moved to Florida for the winter, and he wasn't licensed in Florida. And the entire claim series was denied. Okay. The entire claim series was denied. So just be aware of that. Just absolutely be aware of that. And if they're going on vacation. All right. Let's keep buzzing by because I want to make sure I get your questions. This came up a lot in the chat. So I will tell you that the Federation of State Medical Boards reported a 46% increase in cross-border telehealth violations from 22 to 24. And many of the clinicians, they were unaware that they're seeing patients in another state. Even just once, it requires license or compact authority in that state. What to do and how to check. Again, and I'll put that in there, but you check where they are. You absolutely check where they are. Another thing is you have to watch out. Nobody's talked about this, but this is a big thing that we need to think about. Does your malpractice insurance cover multi-state telehealth? Be really cautious about that. Like, it's not just your license now that you're worried about. What if something happens from a liability perspective? And I'll give you an example. A counselor was seeing a former client who moved to Pennsylvania, and she didn't know that PA requires a specific telehealth consent form. And after complaint, the board opened up an inquiry, not for the care that she was given, but failure to meet administrative law. Failure to meet administrative law. So just make sure that you're checking that license. All right. Did my audio cut out? Can you still hear me? Can you hear me? That might be bad.
You're good, October.
Oh, okay. I'm sorry. I saw it. Okay. Thank you guys. All right. I appreciate it. Okay. All right. So next up, I'm just trying to get through these really. I just want you to know that this came up several times. I I think that, and whenever people talk about, look, I can do telehealth and I can do it from all over the world. And I hear that. And that's like the dream, right? And if you could do it, but be careful about who you use across the world. And let me give you an example of why. If you're using any third party tool that transmits, stores, processes protected health information, that could be scheduling, that could be email, that could be billing. You've got to have a BAA in place. And there are common BAs that clinicians like forget: cloud storage like Google Drive, Dropbox, iCloud, appoint reminders and eFax services, virtual receptionists, or billing contractors. I'm going to give you something that just happened. There was a therapy practice in Oregon who was fined after they used a virtual assistant who accessed PHI from overseas without a signed BAA. There was no breach in this, but the lack of agreement was a HIPAA violation on its own. So you must have a BAA in place. I know I've said that 50 times during this webinar, but make sure, keep a folder with all your signed BAAs and review them annually. And do not rely on terms of service alone. Do not rely on that. So the end-to-end encryption is not optional. It's absolutely expected. You can go to any company and ask them for a BAA. You contact ICANotes, we'll send you the BAA. Absolutely. So make sure every platform has end-to-end encryptions and that you maintain a BAA. All right. And make sure that the apps that you're using are not using geolocation data. And that's collected by a lot of apps, ad trackers, even your websites, that those things can have geolocation data on it. So just be very cautious about that, okay? Again, BAAs from every single vendor. And listen, I have looked up and contact the ticket at ICANotes.com. Contact them and it will get you a BA. Absolutely. Absolutely. All right. I got 3 minutes. So I want to talk about just digital health, and why I got on a tirade is because I'm still upset because rural patients, 26% of them still lack access to reliable broadband. Right? 4 out of 10 Medicare recipients report struggling to use telehealth platforms. This is a problem in older adults. Undocumented and immigrant patients, they have language barriers and they mistrust digital systems, rightly. And so they are often excluded from platform design altogether. When I think of like equity and equality, I think of that means sameness. It means adjusting care to fit everyone in their realities, right? I have great internet, but that doesn't mean that someone like 3 counties away from Charlotte does. And so I think audio sessions are important where video is not viable. You just have to speak to them. And let me explain why. There was this one organization in Arizona and it launched a tech check visit because and what that was is the front staff, they would call these elderly clients a day before and try to walk them through logging into their telehealth sessions, and their no-show rate dropped by 31%. Okay? By 31%. So you need to audit your telehealth workflow through the lens of your least digitally fluent patient. All right, and make sure that they can get access. We're not gonna have time to do case studies. I wanna tell you how to stay audit ready. I think this is a really important. Don't wait for an external auditor to figure out gaps in your system. Pull 10 to 15 charts. If you're working with a practice, some of you are, pull 10 to 15 charts per provider. Check for the missing telehealth elements. Do we have consent? Do we have modality? Do we have location? Do we have the licensure documentation? Review the billing codes. Look at the logs. Use like a rotating audit buddy system just to see, like, that reduces bias. And just do your smart list checks for your core areas, right? Just make sure that you don't need a lawyer on speed dial, but maybe once a year get somebody in to look over to look over your compliance stuff, right? Look at your telehealth consent, look at your BAAs, look at your cross state policies, things like that. And just treat audits like a fire drill, practice them calmly, regularly together, and build a culture of we check it, we fix it, we learn. All right. This is the last one I'm going to go over what we can do today. I'm happy to stay to answer questions, but compliance is not a catch up day game. It's got to be a daily habit. All right. And this is making sure that you update your billing practices for 2025, update your tech stock for compliance, train yourself on best practices. And if you just do one of these things that you see on the slide, if you just pick one and you complete it by the end of the week, then build it from there. Because every policy review, every checklist you update, every team member you train, every time you train yourself, it's going to make you safer and stronger and audit ready. Okay. Safer and stronger for audit ready. I got a lot of questions. People are saying don't hold a session while the person is driving. Absolutely. Yeah. Never. Always never. I'm getting a lot of questions. Can you do it out of state? All the laws point to the fact that the client has to be in the state that they are supposed to be in. Okay. The client has to be in the state that they are supposed to be in, right? Now, where you are, that is nobody's business but yours, okay? Where you are. Now, there are EHR, ICANotes does not do this. We do not track IP addresses, nor do we plan on it. But there are EHRs that track IP addresses, like where you log in from, what IP address you're logging in from. If you're using one of those EHRs, I would find out because they can and would use that against you. All right. But do not, yeah, be really careful about that. All right. I got a lot of questions up here. Let's see. Let's see. All right. So I'm going to start going through these. Yeah. Never ever in a car. Never ever. I've got a couple of these questions. Is it appropriate to conduct telemed appointments if the patient is at work in their car and it's not moving or a friend's house? Yeah, I would make sure, Melody, great question, that they feel comfortable, and that HIPAA is going to be maintained. Or someone might say, I don't mind my friend listening. Sure, sure. Somebody say they're talking about what am I supposed to do? Scan their rooms or their surroundings as a precaution? Here's the thing, you can't legally or ethically treat a client outside of that state jurisdiction. Okay. Licensure laws are based on where the patient is located at the time of the session, not the provider. I want to make that very clear. Where your patient is, not where you are. So if you're seeing a client outside of your licensed state, that is that's unlicensed practice. That's a reportable offense. It'll jeopardize your license. Absolutely. And maybe you could adjudicate that by saying, listen, I can't see you if you're not in the state of North Carolina. Are you okay with that? Are we clear? And again, malpractice doesn't cover it. And here's the thing. If they go and they're at the Disney World having the best time of their life and they like just jump on their telehealth session and you didn't know, that's what the law says is you have to prove due diligence in verifying that patient's location. I will put that statement in. Let's see. When I went to another country, Jessica said, I provided services a few times when I went to another country. During vacation, I used end-to-end encryption, secure VPN with the BAA, and I checked the country's laws about telehealth provider leaving vacation and scheduled clients and scheduled client what's out. Jessica, you get 100%. You have passed. You did all the right things. You used a VPN, you had a BAA, you checked the country's laws because some countries' laws will tell you that you are not allowed to practice telehealth there. So be aware of that. I don't have time to go to all those countries, but there are some countries that do that. But Jessica, you get an absolute 100 on that. That's fantastic. Oh, code for elsewhere like car, work, exactly. The O2, the place of service O2. Yes. You mentioned, let me see. I would never advise holding a session while a person, yeah, no, a lot of people saying don't do it while driving. Yes, absolutely, 100%. Absolutely. If there's other questions, if I didn't get your question, put them in the back. Emily, we have people coming in answering questions. Fantastic, Emily. I don't allow the person, Emily and Steven, don't let them be in a moving vehicle. Fantastic. Um, so yes, they can be in a parked car, not a driving car. And yeah, no high risk situations. Like it's a clinical and an ethical issue. Do we have to go back and change our notes moving forward or just do it moving forward? It's up to you if you want to change your notes. If you knew for a fact that they were there, you can, or you could just do moving it forward. Absolutely. Whatever works for you. All right. Thank you guys so much. Thank you guys so much. I did not mean to cause anxiety during the presentation. I do use a lot of real world examples because I want you to know what's going on. I really do. But yes, it is anxiety producing. And I know we're already at 6 after. Jose, can you recommend some malpractice insurance companies? I can't. I haven't done enough research on that. And if anybody contacts you and says October recommends us and we're on this auditing place or we're malpractice, October recommends no one. Okay. And if you have more questions, I'm going to just put my email down below. You feel free to schedule some time with me. I'm happy to talk with you. about this. So thank you so much. Thank you. Thank you. I just it was a pleasure to work with you guys today. My email, it's not letting me type it in the chat, which is really weird, but it's october@icanotes.com. So it's just october@icanotes.com. All right, y'all have a wonderful day. Thank you. Thank you. Bye-bye.